Hi, everybody, and welcome to the March edition of the Research Roundtable. It is Lymphedema Awareness Month, and certainly this will be a topic of conversation, as will lipedema. And we know that this is a meeting of great minds every month. Our guest, our host and anchor, Dr. Karen Herbst, and all of you, because you bring your brilliance to the table and ask the best questions. And so I want to encourage you as we get started. By the way, I'm Brenda Viola for Lympha Press. If you have questions as this conversation goes along today, please do put them in the Q&A. Let us know you're here in chat. We'd love to know who has logged on and who has joined us this evening. And I have the honor of introducing the guest, and then I will disappear into the shadows and be on the edge of my seat just like the rest of you. Our guest, by popular demand and by order of Dr. Karen Herbst, our Chief Medical Officer, is Dr. Rachelle Crescenzi, a translational imaging scientist. She created the SALT lab. SALT stands for Sodium Adipose Lymphatics Translational Imaging Lab. I know that's a mouthful. The SALT lab was created with support from the National Heart, Lung, and Blood Institute, and it was created back in 2018 at Vanderbilt University. It then moved to the University of Virginia in 2024. Shelley, as we fondly call her, Dr. Crescenzi, more formally, is an award-winning scientist. And we are so excited to sit back and listen to Dr. Herbst and Dr. Crescenzi have an amazing conversation. And again, we are so delighted that Susan from Boston and all the folks from San Diego and even Peru, Minnesota, Mechanicsburg, Virginia, Casey Grosvenor, Carol Platt, Hilton Head. Wow. All right, we're on the edges. I'm going to buckle my seatbelt and disappear. Have at it, Dr. Herbst and Dr. Crescenzi.
Thank you, Brenda. Really appreciate it. And welcome, Shelley. I'm going to call you Shelley, Dr. Crescenzi. We are definitely friends. We have been in the lipedema field together for many, many years. And in addition to just admiring your work and using your work to prove that there is edema and lipedema, we did some crazy things like research at the FDRS conference, and
oh wow!
We had participants in togas, and we've
Excellent.
Definitely had a lot of great experiences together over time. So I just wanted to start. I know you're in transition. You're moving from Vanderbilt to the University of Virginia. So can you just kind of tell us about the move and what your current position is going to be?
Sure. And also I'll just say it's very humbling to be here with you and chatting, to have been inspired and learned from you all of these years, and now be able to talk together about science at this level. I really always appreciate hearing what you have to say and think. So I'm glad to be here tonight. Thank you for the introduction too, Brenda, and for inviting me to Lympha Press Roundtable. I am in transition, but it's a great time to do this kind of talk because I am thinking about where we are and where we're going as a lab. So the move to University of Virginia was really for the whole lab. So not just myself moved, but also our team members, Vanessa and Allison, and they lead our clinical research studies in various aspects. And so I was really grateful to have them stay on board with me and move together as a team. What an honor to have people that you enjoy working with so much. My position is in radiology still, but I'm a researcher in a clinical department. So it's always a bit of an explanation as to why I do no clinical service, but I am there. And we do research about MRI. We try to understand new ways to use MRI, new ways to apply it, in whom, when, and where. And so that's what our lab is about. My position is a faculty position, and I am more than 90% research on my time. So I don't provide too much education other than mentorship through research projects and all that, but it allows me to be really dedicated to research. So I'm so thankful for this kind of position.
That is so awesome. That's really, for those who don't know it, that is a huge gift to be able to spend 90% of your time doing research. And oh, my dogs are going to bark.
mine will too at some point. It's inevitable.
Maybe you can tell us about MRI. What is MRI?
Yeah, sure. I will get started with that. I love MRI imaging. I loved imaging in the body even when I first started in a research lab. But MRI to me is always exciting because it uses magnets, which I think are pretty cool, but it also uses no ionizing radiation to collect an image. So some forms of imaging, like X-rays, have small particles that impact our body, and they can be ionizing, and that has to be managed. But with MRI, it's completely non-invasive. It is a imaging technique that can measure in 3 dimensions in the body, in large areas of the body. And the other cool thing about it, I had a mentor tell me once that MRI can measure anything. And I took that as a challenge. So it's always interesting to come up with how you measure things with MRI.
So you say it's non-invasive, but I do know that you can inject contrast. What do you have to say about the contrast? How important is that for your imaging? Do you always have to use it?
Okay. In the form of imaging that I've pursued, I don't inject any contrast agents or anything outside the body. I like to think of the body's naturally occurring molecules as their own contrast agents. And how can we enhance them and study where they are to create a molecular image? So um, there's no injectables in the methods that we've been using and no ionizing radiation. So in that sense, I like to say it's completely non-invasive. Um,
That's
but
nice.
there's definitely value in contrast agents for sure.
Yeah, because there's, some people who have, I'll call it maybe a sensitivity to gadolinium, which is a contrast agent used in MRI, and it's been known to deposit in tissues and deposit in the brain. So it's really exciting to know that you value not using them, and can I say you value the safety of your patients, and you want to do as least invasive as possible. So that's the goal, right? Is to not have to cut people open to figure stuff out, right? Your
Absolutely. Like that.
MRI kind of cuts them open, and I mean, you get to see everything inside.
Absolutely.
So in terms of, let's just say lymphedema, what are some interesting things that you have seen on MRI in people who have lymphedema?
Yeah. Well, when we first started thinking about lymphedema, I guess we thought of fluid, and MRI is naturally sensitive to water in the body, so it seems like an ideal way to look at fluid. But you'd be surprised at how little work had been done on imaging fluid in lymphedema by MRI. I don't know why, really. But I've seen some interesting images where we tried to highlight the really slow moving fluid that builds up in lymph stasis. And one of the earliest experiments we did was to look at patients who had lymphedema on one side and not the other. So unilateral lymphedema in the upper body. And using this MRI technique that was sensitive to slow moving fluid, we saw the edema in the unilateral lymphedema, but not just in one spot, like you might get with a spot measurement. It was all over in the chest wall, in the axilla. We can look at the lymph nodes, and it was just so fascinating to see where that fluid collected.
So when you say slow moving fluid, what does that mean?
Okay. So slow moving, like compared to blood, for instance, which also has water in it, and you can image that with MRI. But lymphatics are slower than blood. As you know, there's no central pump to the lymphatics. They don't pump as fast as the blood because there's no heart, but they do move, and it's just at a crawling pace. um,
How
it's
about compared to venous blood?
So
It's
slower
slower
even
than
than
that?
venous blood.
Okay, so it's really, and are you imaging only the fluid in the lymphatic vessels, or are you measuring interstitial fluid as well?
That's a great question and a nuanced one. We are definitely also picking up interstitial fluid and the vascular compartment or pool of fluid. So when we visualize the image that's sensitive to edema, you see kind of diffuse patterns that we think are related to interstitium, but also the vascular patterns that are clearly in a vessel of sorts.
So can you see a leak in lymphedema, like a leaky vessel?
Ooh, we definitely see, that stardust pattern that some people talk about with the ICG lymphography,
Yep.
which injectable technique and an optical imaging readout by MRI, we can see also those diffuse like stardust patterns around vessel structures. Um, so I would say we can pick up leaks, but you have to obviously know a little bit about what you're looking at to see that, I would say. It's not always obvious to me. So we work with radiologists who help us understand, what's abnormal or leaky.
Nice. That's interesting. I actually didn't know that about MRI, that you could actually see that stardust pattern. So that's very cool. What about in lipedema? Do you see the same patterns that in lipedema as you do in lymphedema?
Mm. So that would be comparing the legs in both. So
Yes.
let me move my brain down to the legs in a body. Okay. Um, with leg lymphedema on this edema weighted, MRI scan, we see more focal patterns. We see more local spots of lymphatic buildup of fluid. In lipedema, we've seen more diffuse patterns, like all around the leg, and they're deeper. They're not necessarily just at the superficial layer or just at one location. They're more diffuse and they're deeper.
And they're what?
And they're deeper.
That's interesting. When I think of lymphedema, I think that would be deeper than lipedema. But why is that, do you think? Do you think it's because there's a lot more pathology in a lipedema leg than a lymphedema leg, or a different pathophysiology?
Yeah. There might be other reasons to think about the pathophysiology, but I guess just by the image, I don't know why. I mean, it shows us where that edema is located, and there is more tissue in lipedema, so it has more of a space that I can point to and say that's deep. So that could be it.
And in both situations, is the muscle affected or is it not affected?
We're finding new patterns there too, I would say. You know how you do one study in a group of people, and then you do another study in another group of people, and it's not always the same. So we have found in our later work, there are patterns of fluid deposition around the muscle in people with lipedema, and we're trying to understand where in the muscle or how many people have muscle features in lipedema. But there are some cases I've seen more in the later research we've done. And we really don't see that in lymphedema. That is a good distinction.
Oh, wow.
Only in really advanced leg stage 3 lymphedema have we seen that edema patterns change in the muscle.
Huh, so muscle gets involved more so in lipedema and earlier, maybe? Would you?
Mhm. I think
Okay.
so. I think that's a fair statement. I could look at what's the age, of the patients where I've seen some. Oh, we got a question, don't we?
I don't think so.
Okay, greetings.
I think we're still, yeah, if anyone wants to ask questions, I am like banging away here because I am super excited. Oh, we did get one. With your imaging, how do you find women with lipedema differ from the general population?
Mm-hmm. With lipedema, the easiest feature to pick up on MRI is actually the amount of subcutaneous adipose tissue deposition. And that is much thicker in people with lipedema, in some cases 2 times as much as what we would see in an otherwise BMI matched person. Um, you know how I said that fluid was easy to see on MRI because it's sensitive to
Yeah.
water, but also fat is easy to see on MRI. So I just want to throw that out there. Do you have any images to show us? See differences between lipedema and lymphedema. That is a great question. And we talked about this a little bit ahead. I I do love presenting images and research images. I would love to be able to do more of that and could do that after this session, maybe with Brenda. I could send out maybe like a 2-slide or so of some examples. But I'm really going to try hard tonight to talk through our work. So our images are hopefully going to be published soon between lipedema and lymphedema.
Nice. So, Dr. Simaro has this theory of the compartment syndrome, that in lipedema, fat grows around the vein, and that pushes fluid into the muscle through the I guess, indirect perforators, and then up to the towards the skin, or it can just go directly through the fat to the skin. So do you think that that fluid and muscle could be due to maybe increased venous pressure, causing fluid to collect in the muscles and the fat tissue? Like leaky, we know that vessels are leaky in lymphedema. What do you think?
It's certainly plausible. It really is. I've been on a different kick thinking about why that is the fluid is building up, but I think the pressure is a main driver of where fluid goes. And so am I right that this theory is kind of the secondary pathway where like there's pressure from the adipose tissue deposition that pushes back into the venous and lymphatic compartments? Is that the
So
source
it's
of
in
pressure?
the greater saphenous vein compartment. We'll take that as an example. And there's one that runs all the way on the medial side of the leg, and that's got lymphatics and it's got veins. So if you grow fat in there, your veins don't get bigger and they don't necessarily reflux. So you don't have chronic venous insufficiency, but it like squeegees the venous blood back towards the tissue, and the lymphatics aren't moving the fluid up, and that is moving back into the tissue as well. So you're getting both lymphatic fluid and venous fluid entering the tissue. And we know that the venous perforators go through muscle. I don't think the lymphatics
Yeah.
do.
That is a good point. There's definitely some interesting work being done in anatomy on where the lymphatic perforators are, both in upper and lower extremities. I don't think we have good tools to see them. So that's a great point that if we know the venous system does that and we see pathology in the muscle in terms of excess fluid, and that's a really plausible way, because, it doesn't come from, let's put it this way, like I really do think lipedema has a vascular disease component. We don't see the pathologies starting from the skin or starting from, other tissues where you see lymphedema starting. Do you know what I mean?
Right.
And
Yep.
so I do think that's a real plausible thought that it's coming from the venous back pressure, fluid building up. Because why don't we see fat in the muscle then? It's not like all lipedema patients have marbled fat in the muscle. They don't. It's subcutaneous adipose tissue. But the edema, and we'll get into maybe some sodium talk, is
Yeah.
showing up in the muscle more in lipedema. So where does
Hmm.
that come from?
So if you were looking at someone with lymphedema, let's say breast cancer associated lymphedema, how does that look on MRI compared to somebody who's developing lymphedema due to venous disease? Do you
Ooh,
know?
I haven't seen many examples on my imaging techniques with venous, like phlebolymphedema.
Yeah,
Um,
lymphedema.
yeah, I haven't seen very much of that in my examples.
Huh.
Yeah.
Yeah, that might be super interesting, is to look at the different venous patterns of lymphedema, or looking at the different patterns of lymphedema.
When
Because
there's a venous etiology versus, yeah.
versus a loss of lymph nodes,
Mhm.
versus something
We've seen
else.
some primary cases, so that's been interesting.
Primary, yeah,
Mhm.
that's
Yeah.
very cool. I think that, the lymphatics originally, at least a lot of them derive from the venous system. So the fact that they run together in compartments makes perfect sense. And I just would be I don't know, has anyone done phlebolymphedema on MRI? Are there papers out there that we could look at? Because I don't think I've ever done that.
Yeah, I think there are a few. I remember looking up early papers in lymphedema when I first got started trying to image it, and finding a really nice case example where they showed phlebolymphedema from secondary lymphedema due to lymph node removal, and even a lipedema early case example. Do you know what's cool about that paper too?
No, what?
That radiologist is at UVA, is at University of
No
Virginia.
way.
I'm not kidding you. So I ran into them the other day, and
Did you
when
fangirl?
I totally did. They're not necessarily a woman, but I was fanning over them, and I was so excited because I was like, "Oh, you're Dr. Hagespiel? Oh, like the only like one out of three papers, looking at MRI of lipedema and lymphedema really before the year 2000." So it was pretty
Wow.
cool.
That's incredible. So we've talked a little bit about how you do non-invasive MRI. Tell us a little bit more about your technique to look at sodium, as you mentioned, so that we can all kind of understand what you're doing and why you're doing it.
Sure. The technique of sodium imaging is still non-invasive. The body also stores sodium. It's the second most abundant MRI sensitive nuclei in the body. So the first most abundant would be proton, and that's in water. Second is sodium, 23Na, which is naturally occurring. The only thing we need to image it though with MRI is a particular detector. And MRI detectors really work a lot like the radio waves and like a radio detector where you tune your station to a certain frequency. Well, we need detectors for sodium that tune to the frequency of the sodium nuclei. So as long as you have a detector, you can image sodium on your MRI scanner. And we started doing that, I think even in 2016 was one of the early scans. I was also familiar with sodium imaging from my early research as a young student in the lab, and we were studying like degenerative disc disease in the spine and other cartilage diseases with sodium. So it's interesting that it's come back around to me in a different light.
That is cool. So one of our, I would say, collective theories is that sodium binds up to glycosaminoglycans in that interstitial space. So when you image the sodium, like where the heck is it? Like when it's sitting in the fat tissue or in muscle, where is it in those tissues?
Mm-hmm. It is what we see on MRI is mostly extracellular sodium, and it's mostly bound sodium to
Okay.
something that's negatively charged. So,
Okay. That
yeah.
makes sense. So to glycosaminoglycans, right?
Yeah, I think that is, yep, I think that's a primary biological contrast mechanism, or a primary like concentrated species in the tissue where it binds to. Of course, I'd love to get some biopsies and be able to measure that directly. It's been done in other cartilage tissue where sodium directly corresponds with the amount of negative charges with glycosaminoglycan concentration in knees and in spine, but I would love to see it in fibrotic fat.
So you mentioned fibrosis. So when somebody has, I guess, lymphedema, and maybe they could say something also about lipedema, when they have fibrosis in the tissue, what does that look like? What does the fascia, like a sick fascia, look like on MRI? And what does a healthy fascia look like?
Mm-hmm. You know the term honeycomb pattern that would come up in the literature when they're describing legs with lymphedema or arms. And so the honeycombing pattern is mature fibrosis that's showing up with a lot of water density on an MRI scan. The sodium follows water as well, or water follows sodium. We think of it that way, really. And so the sodium also has patterns of kind of texture in the fat tissue. And
Mhm.
wherever there's fibrosis in the adipose tissue of lymphedema, it's usually more focal and it's the most concentrated sodium. Like at least twice as much sodium is measured there as in other regions that are not fibrotic in the adipose tissue of lymphedema.
Wow. Why is that?
I think it's those negative charge species, and the body has a natural mechanism for sequestering, excess fluid and inflammatory sodium. And so it
That's
just
so cool.
sinks right in.
So
Mhm.
fat is, when I first was going through medical school, whenever I would hear about fat, I would get so excited, like, oh, they mentioned fat. This is so cool. And the omentum, the fat in the abdomen that's kind of hanging off your stomach, they call that the policeman of the abdomen. So wherever there's inflammation, that omentum kind of goes and hugs around it to protect it. Whenever
Interesting.
you have an infection, fat will grow around a lymph node. If you have inflammation like in Crohn's disease, fat will grow. So I
Hmm.
think that in addition to just fat itself growing, that the body uses these glycosaminoglycans, as you said, to protect against excess sodium and excess water, right?
Mhm. Mhm.
And if we have leaky vessels and lipedema, lymphedema, then you're going to
Mm.
upregulate your glycosaminoglycans, right? Which would increase the size of that interstitial space in all cases, right? And
In
even
all
in
cases, you say?
obesity, because with people who have like non-lipedema obesity, let's say, they
Mhm.
also have been shown to have increased glycosaminoglycans because they are at risk for developing lymphedema. Is that
Mhm.
correct?
Yeah, that's correct.
And have you imaged the lymphedema in people who have obesity and non-lipedema obesity?
Yeah, absolutely.
And
We
what
do
did you
have
find?
yeah, obesity cases do have more muscle sodium than fat sodium. Different compartment. I like the fat story though. Um,
Interesting.
yeah, it's still relatively clean even in obese individuals. It's hard to compare them to non-obese individuals, but I guess we could look at those fat sodium levels there too. I say that only because they're typically younger as well, and so there's an aging effect on how much sodium is deposited. Um, but yes, we've seen lymphedema with or without obesity stores sodium in the fat tissue. Lipedema with and without obesity stores it in the fat tissue. But we have some new findings about people with lipedema who also have lymphatic insufficiency symptoms like lymphedema and how much sodium they have and where. So that's another story coming out, we hope.
That's awesome. You're learning so much. And I really appreciate all this knowledge coming out and helping us with the pathophysiology of lipedema. And I'm glad you said it's a vascular disease because I said that early on and everyone told me it was only a lymphatic disease. So it's really good to see us broadening our horizons to learn more about it. So I'm going to go to the questions.
Sure.
Cynthia Mason asks, can you have normal sodium for a blood test, but have excessive sodium in the tissues and organs? If so, how do you reduce the excess sodium?
In the tissue. Yes, you can. In fact, the blood maintains its sodium levels to only 1 or 2 units change, right? Our blood sodium is about 140 millimole per liter, and you can correct me, Karen, but I think it goes up
You're
and
right.
down, maybe 2, if that.
If
Um,
that.
yeah, if that. The body would be very unhappy if it went more in our blood system. So the blood tries to maintain sodium very tightly. Where else is it going to go, right? We either have to excrete it, so you're going to find it in the kidney, you're going to sweat it out, but it pushes it into the tissue. It can sit there. We found that this tissue is a new compartment of storing sodium. And I forget the second part of the question, to be honest. How do we get it out?
You had to get it out. That's right.
Okay, right. So we are studying this vascular disease along with sodium because we think it's an exit problem, why sodium is there, and you can push it out with compression. So we saw in some pilot studies that patients with tissue sodium undergoing standard of care like decongestive therapy with compression can reduce their tissue sodium. So maybe it's being pushed out. But we also think about the possibility that stimulating the lymphatic system should be able to increase that exit pathway of sodium through the vasculature, not just through the kidney and normal excretion patterns.
So I was just wondering if you've ever done a study before and after pumping. For example, the Lympha Press can reach up to 90 millimeters of mercury, which is like that'll turn you into a lollipop and squeeze all the fluid up into your head, but you wouldn't necessarily do it at that high value. Usually we're at 40 to 50, but I would think that a really nice hard squeeze and hold and press might be a great way to actually see it happen in real time.
That's a great idea. I love that
Yeah.
experiment. I have not had a chance to do that.
And I know that, pumps have been shown to decrease fibrosis. So they're obviously doing something.
Mhm.
And then I had one other question for you. Oh, where did it go? Oh,
So it is
and
kind of dynamic. Yeah.
so you and I talked years ago about dextroamphetamine. And
Mm-hmm.
dextroamphetamine improves lymphatic pumping and decreases fat, decreases fibrosis, and acts as a diuretic. That would be another really interesting study to do that you could do in a very short period of time because it is the only known medication on the market that improves lymphatic pumping. And it's
Wow.
cheap and easy to get. It just happens to be a controlled substance, but that's the downside to it. So you have to, report that you're prescribing it for somebody, but you can use it in very small amounts and it works like really super well in some people, of course, not everybody, but that would be another one that I would love to have you do.
I love these experiment ideas. We've got mechanical pushing, we've got a pharmaceutical mobilization. What other ideas you got? Let's try
Well, GLP-1s, of course.
GLP-1s,
Since
SGLT2s. Interested in those.
SGLT2s.
From a research perspective, I'm interested, like I, would always have to work with a clinician to understand how these therapies could be applied. But for just the research question of what mobilizes tissue sodium, it is on my mind for sure.
That's awesome. Let's see. This is an anonymous attendee who says, is the lipedema fat seen all over the body or just in the legs and arms? Which is like our big conundrum between us and some groups in Europe, particularly Germany, that say that lipedema can only occur on the legs. That it is basically just an obesity, that there is no edema and lipedema. And then they also ask, does it progress with age? Do you see it on the abdomen? Do you see it on the chest? Lipedema?
We don't have abilities to look at something like sodium in those areas of the body yet. But the amount of subcutaneous tissue can be thick in those areas of certain people. I think a better tool is really histology to answer that question. So I do think we have good opportunities to pursue that kind of research. But in my lab, we haven't been able to do all of that yet. But some of your work showed, abdominal studies compared to thigh studies, and there is a big question about where are we even going to take a biopsy to look at lipedema fat. And my guess though is it's deep and it could be there. It kind of gets back to the question of, why is lipedema there? Is it acquired or is it all over the body? I guess that's the question.
I think it's a systemic disease, and I don't think that there's a fine line in the groin that says no lipedema tissue above here, that it's, everything else is obesity. But I think with your work, someday we're going to be able to figure out, how do you tell the difference between lipedema fat and non-lipedema fat? I think it's coming, but I think they're so intertwined and so mixed that it's going to be difficult. But maybe you could find some people that have, that shows something, because everybody's different. Like you said, you learn from probably everybody you image.
100%. Everybody is their own case example. And, trying to put together a conclusion from that has been fun and challenging. I wish I could show, honestly, every single case that has come through and just allow us to interact with that. I do think we need better ways to publish what we find in kind of broad, page limitless ways. So I have thought about that over the years. We really need almost like a couple chapters of just case examples in lymphatic disease imaging, because it's so understudied.
Yeah.
And some of us have sat on this data. It'd be nice to put it out there as some case series, but
because a lot of data, I'm sure people just, fold their books and retire, and it just sits there.
Yeah, wouldn't you love to see some old lab notebooks of early anatomists?
Yeah. So
these great questions too, honestly. Thank you.
These are amazing. Do you want to answer any? Do you see any that you want to answer?
There are so many. Do I start back at the top?
There was a question about clarifying the name of the medication for lymphatic emptying. A couple people asked that. So
that's dextroamphetamine. It is an amphetamine. It is a controlled substance. You do have to take it with care. There are some side effects associated with it. It's the same kind of medication you would use for attention deficit disorder or ADHD. And it is found in combination with amphetamine salts and amphetamine as Adderall. So it is it's a very pure form, and it's one of the 3 components of Adderall. And it is approved for the treatment of obesity, just like phentermine.
Thank you so much. I know that was a topic of interest. There was also the question about, how do abnormalities in the fascia present on imaging? Dr. Crescenzi, can you speak to that? Do you see webbing and strictures?
I'll answer some observations both in lymphedema and lipedema. In lymphedema, we certainly do in the advanced disease cases, and those fascial textures have been reported as that honeycombing pattern. In lipedema, it's not always as apparent and as thick, I would say. So we really have to do a good job of observing it and measuring it better. It's not apparent to the eye, let's put it that way. But there is a lot more kind of speculated and diffuse features of what looks like that, fascial components. I know that's not a great answer, but it's different in each person. Some people do not show features of, visible thickening of their fascia in lipedema, and some people do. And so I think the question comes up so often, we should just measure it and have an idea in mind, but don't have that done yet. So thanks for the question.
There's one here. Is Sandra Willis says, is this technique being used to investigate central lymphatic disorder? So, leaky truncal vessels.
Mm-hmm.
But I don't think you can measure sodium there, but you can look at the lymphatics.
Right. I was just thinking of the non-tracer lymphangiography imaging can be applied in the central torso, and you would pick up edema and fluid as well as the vascular structures. And I have not come across many case examples that I've been able to study, except one in a children's hospital that was interesting. They had idiopathic edema in their upper thigh, and we did a whole body lymphangioscan, and we were able to see it coming up from the abdomen too. Or coming down from the abdomen. That was really interesting. You will find more tracer-based techniques being used in the abdomen for historic reasons, but we're hoping that a non-invasive tool could be more widespread and provide that quick view of where edema is. And I'd also love to study sodium in the abdomen, so it's been on my mind.
So when you say tracer-based techniques, do you mean like a radionuclide, like in nuclear medicine, or what are you talking about there?
Both that, but I had in mind the gadolinium injections
Okay.
with MRI that are used to study lymphangiography.
Yeah. Okay. Yep. Let's see what else we got here. Are there recommended sodium intake levels for those with lipedema?
Nope, not yet. And I'll just say that it's not clear that the tissue sodium is directly tied to someone's dietary sodium intake. So it's not clear that changing your diet and sodium levels would even impact your tissue sodium. In fact, in lymphedema, we just analyzed all of our 24-hour urine collection, which is a standard way to look at how much sodium people intake is how much they excrete. So the 24-hour urine sodium in lymphedema did not relate to tissue sodium whatsoever in those patients. And they, of course, store a lot of sodium in their legs. So we're following up to understand that same analysis in lipedema. How much does urine sodium as a proxy for our dietary sodium relate to tissue sodium?
That's so complex.
Yeah, the total compartment measurements of.
My gosh, yeah. I think that hurts my brain just even thinking about trying to figure all that out. So thank you for working on that. Let's see, let me see my questions that I had for you. So we already talked about your sodium. So tell us, so when you go to a new institution, you have all sorts of new people that you can work with. Have you already kind of thought about some people that you would love to work with there, and on what kind of projects?
Sure. I'm very excited to have good, close connections with a few departments at UVA that I'm getting to know. One of those is in plastic surgery. And I was, the earliest talks I had with University of Virginia was with a plastic surgeon, and their interest in lipedema as just a really understudied and underserved patient population. And they were looking for a researcher as well. So we began talking. They're starting at UVA or have started a research division. So I'm going to work closely with that division. And our really good colleague between the two of us is Dr. Sarah Algadban, and she joined us at UVA too. So we are starting to centralize our research expertise, and I couldn't be more excited to get started with Sarah here almost at the same time. So she's, I mean, number one on my list for collaborating with, because, she brings all of the expertise of looking at adipose tissue in cell culture and in histology. And um, I cannot wait to pair that with imaging.
That would be so awesome. As we've talked, in lipedema, we always talk about the fat, the fat, the fat, the fat. But what I've heard you say is that the muscle is quite affected in lipedema. Would it be interesting to look at myocytes or stem cells from muscle tissue to do some muscle biopsies, look at muscle structure?
Hmm. It would be interesting. I would look at the mitochondria if I had muscle. I mean, maybe this is obvious, but I would be interested in the energetics of the muscle tissue in lipedema and what is and is not supported in their function. Um, it would be
Because we really
interesting.
don't have biopsies of muscle and lipedema,
We
right?
don't.
Nobody's
No.
done that. So you don't have stage 1, you would expect normal muscle. Stage 3, we do see that fat starts to enter the muscle compartment. So you would expect to see a different structure. And I always tell, and I could be wrong, but I always say, just like your fat's in a cage, your muscles are in a cage too, and they can't contract and generate the force that's needed to give you the motion that you need and to pump fluid out of your calves, especially.
Oh, great point.
So it would be interesting to better understand those mechanics. And when you do liposuction, you kind of free up the muscle. And, I've heard so many women say, yeah, now I can contract my calf. Whereas before wasn't able to do that. It kind of moved as one big chunky unit. And I would imagine with lymphedema, there's still, even though you say the muscle's not as affected in lymphedema, there's something similar going on there,
Yeah,
right?
I think the border is important to pay attention to, like that perimuscular border or the fascia around the muscle, even in lymphedema. And I'll just throw out some interesting new findings in the lymphedema studies is that the anterior adipose tissue is more affected than other areas of the
Mhm.
leg. And that's in cancer-related lymphedema of the leg, where a certain territory of lymphatics has been disrupted. So we see anterior adipose tissue changes. And it's right along, the front of the leg. And in
Mhm.
lipedema, where we see those fat pads developing in the front of the leg,
Yeah,
like
and the medial
how,
part.
yeah. And
Yeah.
how when we move our calf, we want to think about the back of our calf kind of contracting, but how about that front muscle too? And so I think about the leg differently now, and I'm trying to understand its anatomy, and how the fat and muscle interact between that fascial border. But maybe you'll give me insight on different compartments and how they pull each other. Anyway, that's where my mind has been lately, comparing the muscle and the
Yeah,
fat patterns.
I think the fact that you brought the fascia in between the muscle and fat really is important. And we don't really understand what's going on with that deep fascia. We do know that the superficial fascia, well, even the deep fascia in later stages of lipedema can just turn into pure fat.
Mm.
It gets so infiltrated with fat. So
And
it's
that's in
like
like the stage 3.
hmm?
That's in like the stage 3 cases.
The stage 3, yeah.
Yeah,
Yep.
see, I'm excited to work in plastic surgery or closely with them because they'll see more advanced cases going, into liposuction, and we can kind of see sometimes the more extreme areas of pathology there. Um, MRI has been limited by, certain sizes of body shape, so I haven't always been able to image and see, the largest of legs or girth, but new techniques, new technologies, hoping to be able to see all stages better with MRI and um, pretty excited to partner with plastic surgery here in their research division, try to figure that tissue out and what's going wrong there.
Yeah, because I just wonder how sodium affects the functioning of cells. Is it the sodium that's changing the stem cell behavior because it's in a high sodium environment?
Mm-hmm.
Do you think that could play a role?
I don't know as much about stem cells as Sarah Algodvan does, so I'm hoping to learn more from
Better
her.
talk to her about that.
Better
Yeah.
talk to her. But I've been thinking about sodium ion pumps and how there's many different kinds of sodium ion pumps on the membrane of our cells. And so that high sodium environment surrounding a cell has got to be changing some of those or interacting with them. I'm a little bit interested in pain receptors on cells and how that's interacting with sodium, and where that's occurring. So,
Well, that could also, the sodium in the interstitial space can affect the fascia, because fascia has 6 to 7 times more pain receptors than muscle. So
oh,
it's
wow.
it's got to affect that fascia, right? And if fat's growing into your fascia, that's got to affect the fascia. So there's a lot of fascia things going on. And we know that women with lipedema, a lot of them have hypermobile joints.
Mhm.
And yeah, we're looking at the genes, and
Mhm.
in more of a kind of a wide N of one view. So everyone is their own person. So looking at personalized genetics, and there's a lot of really cool connective tissue genes that have come up that are not your typical collagen genes, but a lot of collagen genes have come up as well.
Mhm. Oh, that'll
That,
be awesome
that
to
would be
see.
interesting to know, when you're looking at people, what kind of connective tissue issues, kind of, gene mutations they have.
Yeah, absolutely. We've brought this up in the past, sort of subtypes of lipedema or taking other phenotypes, as we might say, and understanding their genotypes. And I'd love to understand their radiological profiles as well. See if we can develop, again, a non-invasive test to understand someone's, genetic and phenotype history that might tell us what kind of trajectory they're on in their disease pathway. Um, but we have
Yeah,
a lot
because
of work to do. We have
there's
to work together.
there's quite a few women with lipedema that I've seen recently who have TNXB mutations.
Ooh,
And
tell me more.
that's classic like Ehlers-Danlos. And
Mm.
it's part of the extracellular matrix. And the way you can examine for that is you look at their elbows, and you're going to look for a thickening of the tissue there, but
Hmm.
not really obvious scars, really big scars. That's classic
Hmm.
EDS, but thickening of the tissue right at the elbow and also right under the kneecaps. And you just kind of feel for it, and you feel that rough area. And if you
Hmm.
ask them, you're like, do you know you have this roughness on the elbow? Yeah, I've had that, forever. And I scrub it off.
Yeah, of course.
So, and I've usually been right. I'm like, oh, you're a TNXB. And then we do their genetics, and sure enough, they're a TNXB. And
And they have symptoms of lipedema too?
oh yeah, these are women with lipedema that I'm talking about.
Hmm.
So, and I think they have probably the leakiest tissue.
Mm. Okay, interesting. The
So maybe
leakiness.
in your physical exam, when you're working with Sarah and plastic surgery, put on the rough skin on elbows and knees to your physical exam and see if we can
Got it.
find a bunch of TNXBers.
That's so cool, the elbows. Can you always keep us like moving around the body, like hands, elbows, back and neck? Don't forget it all. Come on. We just need a whole body scan, by multiple tools. And
Well, if you think about it, if connective tissue is a systemic disease, why wouldn't lipedema be a connective tissue or a systemic disease? It
Mhm.
just makes sense. It's just, I think, your understanding of fluid, sodium, and pressures,
Mhm.
that all that comes together to generate a particular phenotype. And if you have really loose, leaky tissue, you're going to grow a lot more fat, and it's going to be in a more dependent position. So you're going to grow it on the lower part of the body. And then,
Mhm.
the arms are going to follow, and then the belly is going to start hanging down. That's kind of a typical TNXB mutation. And that TNXB is in the RCCX complex, and that's linked to the gene CYP21A2, which makes cortisol. And so those are, if you have a mutation in TNXB, it's likely that you have one in CYP21A2. And that is lower cortisol. And then your corticotropin releasing hormone goes up because it's trying to make more cortisol. And then that activates mast cells, and then you get inflammation.
Oh, we need to talk about mast cells for sure. Yeah.
Yep. So
It's
there's one way to get lipedema is just by having a connective tissue disorder. And then there's other people who are stiff. They don't have a connective tissue issue. They don't bend differently, but yet they still have lipedema. Where did they get that from? And
That
though
one
a lot of times those people, in my, humble opinion of seeing a lot of women with lipedema, have venous disease, and they get perivascular fat, and that includes the compartment syndrome.
Got it. So you've been narrowing down those two types there.
Oh, I've been looking at all sorts of stuff. I don't think I'm narrowed quite yet. I'm still wide open because I, don't really know what's going on. But I do say, your connective tissue disease and your mast cell disease and your vein disease are all contributing to your lipedema. And because of all that inflammation going on, you've developed some metabolic disease, which is like the worst thing you can develop if you have lipedema. You've got to get that inflammation down, because that really is going to make a person progress. So we treat the metabolic disease, and then get them some vein treatments and get them in compression and get them in their pump, and get them eating a little differently sometimes. But like a lot of women with lipedema come in and they're already eating great, they're already exercising great. There's not a lot to change. So anyway, let's see if there's any more questions. So Linda Ann Kahn asks, can you see the difference in imaging between the superficial and deep fascia and the neural fascia? Oh, there you go.
Neural. Okay, give me a definition of that one. Like neural, not neuronal, or are we at?
So nerve. So any
nerve.
fascia, like, can you see nerve specific fascia?
We could try. We haven't tried, and we could try. I find it interesting that lymphatic imaging techniques by MRI are closely related to nerve imaging techniques. So the same techniques that pick up nerves are picking up lymphatics. Again, thinking about these bundles that travel together, so it's not surprising that they might look similar, but I think we could do a better job of imaging the nerves and trying to understand their relationship to fat and sodium. So do I see a difference in imaging between the superficial deep fascia and neural fascia? I think to study that, we'd have to have more of a biopsy or a microscope view along with the MRI, which is where we're headed. And that would be pretty cool to do.
That would be cool to do. I think that's, on the horizon, Linda Ann. And Azita Yashar says a majority of people with lipedema also suffer from hypothyroidism, which is true. And ironically, these people need more sodium to keep their blood pressure high.
That is interesting.
Yeah, well, a lot of people with connective tissue disease also have autonomic dysfunction, and they need sodium to keep their blood pressure up. So there's a lot going on there.
Is it effective in those patients though? Not being a clinician, is eating high sodium effective in maintaining higher blood pressure for those patients?
Yes, it is. It's very helpful.
Okay. So
let's see, Lisa.
I'll just say to that, the relationship between sodium and hormones is something we want to study better too. Again, with Dr. Algaban, she has good ideas and hypotheses about hormone regulation, and it should impact our steroids, and our hormones should impact tissue sodium storage in ways that I don't understand yet. So
that's cool. That links really closely to lipedema. Dr. Crescenzi, thank you for doing this research. When do you hope to be able to share some results, conclusions from your study? I was a study participant and had a wonderful experience. Oh, that's so nice.
I miss you all so much. I haven't been in the lab for like a long time now doing this transition, and I do miss it. And so does our team. And we are actively writing up our study results right now. So we're really looking forward to publishing two big pieces of work, one from the NIH study of leg lymphedema using this imaging approach, and the other in leg lipedema using this imaging approach. This is where we're going to be reporting on the sensitivity of a bedside tool to distinguish lipedema from females without lipedema, and from lipedema with lymphedema, so lipedema plus, and by bedside exam or by MRI. And I can't wait to share those results. That was done with a medical student, Yinan Zhang, who's now a radiology resident at UPenn, and with our postdoctoral fellow in the lab, Michael Pridmore, who's now an MRI physicist at Vanderbilt University Medical Center. So they've moved on. We're still wrapping up the paper. I've moved on, and we are ready to start that study in a new way, in a new chapter at UVA, but can't wait to share those results. So
That's really exciting. So Chuck asks, it's kind of more back to that fascia question that Linda Ann was asking. What about the interrupted superficial fascia seen in lipedema on ultrasound? Are these visible on MRI or sodium MRI?
I do have to look at that more. I get that question a lot, and because of the ultrasound work that's been done, it
Yep.
is super interesting. I think to answer it, we just need to take some careful measurements of what I'm going to call the texture of the fat tissue on imaging and see if we can create good quantitative measures of that texture.
That's great.
Mhm.
So we're all hoping for that future tool, and your new paper that's going to come out is definitely a step in that direction. Do you foresee us being able to do a bedside diagnosis of lipedema?
By bedside, I think there's some really promising tools out there that don't require imaging. I think the most sensitive feature that we've been able to quantify is the amount of subcutaneous adipose tissue and even leg girth, by association. So things like perometry, we tested leg circumference, used a 3D stereo camera to measure limb volume. So just limb volume alone, I think, can get us pretty far, and studying that in relation to height and some anthropomorphic measurements is what I'm saying there. I think those will get us really far. But then I think we have to add the measurement of a fluid tool on top of it. And that's where we're
Yep.
going to start to distinguish between lymphedema and obesity and with lymphedema. So that's what we're going to come out and show the value of, volume, fat and fluid measurements by bedside and MRI.
We
So when you're
are
done
at
with,
I'm so sorry, but I'm the timekeeper here, and seeing that we have less than 5 minutes left here. I'm sorry, I didn't mean to cut you off, Dr. Herbst. What were you
oh, that's
about to
okay.
say?
I was just going to say, Shelley, when you publish your paper, will you share it with Lympha Press so we can post it online?
Oh, sure. That would be great. I'd love to hear feedback too on it and see how people interact with the ideas that we're going to put out there. So it's always really
Great.
helpful.
And
Yep.
did you give us a time frame of when we're expecting this to go public?
Dr. Herbst knows too, publishing is a unknown and long road. So we will do our best to publish the best story in paper. That's always my goal. And let's see, this year, I would imagine.
Yeah, this year.
Okay. Okay, that's a
Definitely
good
this year.
target. I love that. We
Yeah.
just had such wonderful questions from the audience.
We did.
We didn't get to everything, but we are at the under 3 minute mark here. And so I just want to close things out with, by the way, what are your main observations, Dr. Herbst? And then any closing words from you, Dr. Crescenzi? For me, my big takeaway is we just opened up a can of worms with all these other things that need to be researched. And yet, what hope it gives to know that such great, dedicated people are on the case. And before we went live, Dr. Crescenzi, you were saying that you're still doing this, and you do this because you really care. And, in your words, it was about hope.
Mhm. Yeah, we still receive a lot from the people that we work with, and that includes the patients. So I feel like it's both a give and a take. We would not be doing this if we didn't have people alongside us that are teaching us every day about it. So that's where we get new questions, and it starts right here in just having these discussions, knowing what people are thinking about in their daily lives, and the frustrations that they may be having. That can really drive really impactful research questions. There's so much we could study. We want to study the most impactful research questions that are going to make a difference in people's lives. So I cannot wait to do some of that with some new resources and team that we have with us. And it's been a really great past 10 years, maybe getting to know Dr. Herbst, almost 10.
Yeah.
Like, really wouldn't be doing this without you either, in your pioneering work, loving fat tissue and bringing it to light. That's why we're here talking about it still. So I appreciate you too. And thanks for letting us share and talk about it tonight.
Yeah, and I think my biggest takeaway in the 1 minute we have left is that I think you have the potential to look at these tissues as they interact together, the fat, the fascia, the muscle, and it brings in all the different complications and pieces of lipedema, lymphedema, and there's so many nuances. Like if you have more venous disease, you have more if you have obesity associated lymphedema, if you just have lipedema. I mean, it's so complicated, but I think you have a chance of making a really big discovery. And I am going to be so excited as I zoom off into retirement at some point to continue to watch your career.
Oh, it'll be great to understand that together. Thank you.
That was not an announcement. You're not going
No,
anywhere anytime
no, no,
soon.
no, not
We
yet.
don't want to create a furor out there in internet land. Gosh, thank you so much, everyone, for giving us your time, for logging on, for the brilliant conversation. We heard more than once tonight that lipedema is a vascular disease, or the hunch that it is. And Dr. Lindy McCutcheon, who is a vein specialist, is our guest at the April Research Roundtable. So put that on your calendars, tell everyone. And thank you all for being engaged tonight. We're all working together for the same thing, and Lympha Press is honored to support all of you, clinicians and patients, in your journey. Have a great night, everybody.
Thank you.